Okay, just waiting for a few more people to show up. And before we get started, I'll just give a brief introduction. Again, I normally do two types of webinars. My name is Dr. David Kanashko. I'm the medical director of Bioflex Laser Therapy. We are a photobiomodulation medical device company based in Toronto, Ontario, Canada. We've been in the business of photobiomodulation for over 3 decades, pushing 4 decades now. So we were probably the first manufacturer of light devices like these in North America, and probably one of the first in the world as well. So we have a lot of history and background and clinical background into photobiomodulation. I do two types of webinars. One are for consumers like yourselves that maybe have home systems, like our personal therapy systems. That's what this one is geared towards. You'll always know that because in the title, I say personal therapy system. Anyone's welcome to watch any of these webinars. They are complimentary. I also do professional webinars where I get more into specifics and geared more towards our health, our professional grade of equipment, and a lot more into the research and specifics because typically I'm dealing with medical professionals that have a bit more of a background, although consumers have sometimes big, nice backgrounds as well too. So that's the deal. If you have any questions as we go along, just type them into the Q&A box. In the chat box, let me know your name, where you're from, where you're listening to. If this is your first webinar, that's always fun and interesting to know. And like I say, if you have any questions, let me know in the Q&A box, and I'll definitely get to those at the end of the webinar. The webinars are always recorded and they are edited and then they're uploaded to our website. And typically we send out a webinar, an email within a week or so with a link to watch it again. But if you don't get that or whatever, we don't get a chance to do it, it is always uploaded to the website within a week or so of the broadcast date. So today's webinar is about treating some common skin conditions. Now I'm going to preface this by saying the personal therapy systems in general are not designed for treating skin conditions. They're designed for treating musculoskeletal aches and pains. So that's the key thing here. But you can use it off-label use. And sorry, I'm just looking at someone's question here, which I probably shouldn't do. And I'll get to those questions a little bit later. Let me back up a bit here. So you can use them for off-label use, but that involves kind of tweaking the protocols. And so you might use different protocols or different timings of these protocols to treat some of these off-label conditions. And that's what I'm going to get into today. I'm going to talk really probably about 3 main common skin conditions, although there's a lot more. I'm definitely not getting into acne. I've already done one on acne. These are for other types of skin conditions that are very common amongst the population, and you or someone you know might be suffering from them. And I'll talk about how photobiomodulation therapy may be helpful, and then how you can use the equipment for that. I'm going to review the skin and these conditions, and then specifically why light therapy might be helpful, and then how you would use our equipment to treat these conditions. Okay, so those of you who aren't familiar, we do manufacture in Toronto these 2 types of personal therapy devices. One's called the P120, one was called the P180. They differ in the number of diodes. That's what the number reference is, the surface area they can treat, and to some extent the power. There is a little bit more power output in the diodes in the P180 compared to the P120. And what's important to understand is that the diodes used, these are super luminous diodes. They're like a hybrid between an LED and a laser diode. They're still safe to visualize with your eye. They're very similar to the professional grade that we use in our professional equipment. Slight differences, but they're very similar. The diodes themselves are bicolor, meaning that they emit both red wavelength, roughly 660 nanometers, and then near infrared, roughly 3840 nanometers. These are the wavelengths in the range that are typically used in research over the last several decades. So whether it's 630, 640, 650, 660, 670, in that range is red. And near infrared, typically it's 780, 800 up to 830, 840. Sometimes they can go as high as 900 to 1,000. But as you get higher, the mechanism and probably the targeting is a little bit different because it's more geared towards water absorption, which might have an effect, but they're still kind of looking at that. The controller looks like something like this, and you can see that they're all anatomical regions. So it's simple to use. If you have neck pain, hit neck, hip pain, click on hip pain, that kind of scenario. There are 4 different ways to control it. Turn a power on to stop the treatment if you want to stop it completely, or to pause or start the treatment. And then if you want to select the stage or the intensity level, which I'll talk a little bit about later as we progress. So this little quote I got from a paper you can see at the bottom reference here, and skin diseases are ranked as the 4th most common cause of human illness. So if you haven't had a skin condition, consider yourself quite fortunate, because almost everyone has, to some degree, has some type of issue with their skin. Obviously, skin is the largest organ in the body and covers the body's entire external surface. And it is made up of 3 layers: the epidermis, the outside layer, and deep to that, the dermis, and then the very deepest layer, the hypodermis, or subcutaneous region, all 3 of which vary significantly in their anatomy and function. And fortunately, the light that we use in photobiomodulation, both red and near infrared, can penetrate into and through these different layers. So it makes it a great form of treatment to get and to actually stimulate these different layers. The skin structure is made up of an intricate network, and basically it serves as a barrier, obviously, against pathogens, ultraviolet light, chemicals, and mechanical injury. It also helps to regulate the temperature and amount of water released into the environment. Just very briefly, I won't get into a lot of specifics, but you can see here the different substructures of the different layers of the skin, including the epidermis. And what I want to point your attention to are a few things. There's 5 cell types, or sorry, 5 layers in there. Stratum, which is like Latin for layer. Then you have corneum, lucidium, granulosum, spinosum, and basally. I don't know how to pronounce that one. I shouldn't, but at this point, going from superficial to deep. The stratum corneum is the outer part, which has keratin, and it's the most protective part. And this issue, especially in a condition I'm going to talk about, psoriasis, is the one that goes a little bit haywire to create the plaques or the lesions. Then deep to that is a dermis. You can see there's 2 sublayers, the papillary and the reticular. And this is where you have a lot of nerves and blood vessels. And then you have the deepest layer, the subcutaneous or fatty tissue hypodermis, sometimes it's referred to. We see sort of fatty lobules, some more blood vessels, that kind of thing. Of course, the thickness of the skin varies depending on the region of the body that you're dealing with. The cell types in the epidermis, the keratinocytes, these are the predominant cell type, and they produce, as I mentioned earlier, keratin, and this is the main barrier to water. It also is important because keratinocytes regulate calcium absorption by activation of cholesterol precursors by UVB, ultraviolet B bandwidth. I think that's in the 300s wavelength. And of course, it forms vitamin D. That's why getting out in the sunshine is really important to get vitamin D production. You also have a cell type called melanocytes. These are also super important. They produce a pigment called melanin, which is responsible for blocking excessive ultraviolet light from entering into the body. UV light is ionizing, so it can actually cause damage to DNA and maybe even cause cancer. Of course, we know that through skin cancer and so forth. So really, melanin is your built-in sunscreen. The more that you're out in the sun, the more that these melanocytes are triggered to produce more pigment and hence a tan. Then you have Langerhans cells. These uptake antigens. Sorry about that. Antigens, maybe I need a glass of water. Boy, I didn't have a glass of water here. Antigens are basically types of proteins that are picked up. That could be a bacteria, it could be a chemical, it could be anything that's negative or foreign to the body. And the cells actually help to protect against these foreign bodies, and then it transports it to the lymph system, where eventually they make their way out of the body. Then you have Merkel cells. These are sensory cells, mechanoreceptors for light touch. Think of these are really common in the fingertips, obviously, because that's where you have so much touch. Then deep to the epidermis is the dermis. And this has two layers, the papillary layer, which is loose connective tissue, and the reticular layer, which is the deeper layer. It's thicker and less cellular and has dense connective tissue and bundles of collagen fibers. In general, the dermis has the sweat glands and the hair and hair follicles, has little papillary muscles for triggering the hair follicles, sensory neurons, and blood vessels. So it's quite an important layer within the skin. The hypodermis, as mentioned earlier, is the deepest layer, and it has basically also called the subcutaneous fascia, and has this adipose lobules, things like hair follicles as well, and sensory neurons and blood vessels. Well, so in my research for today's webinar, I found out that there are over 3,000 known skin diseases. So that would take a long time to get through. Fortunately, I'm only going to cover 3 today. So that's what, 0.01% of those 3,000. But these 3 I'm going to cover are pretty common, and these are ones I tend to get a lot of questions about. So I'm going to focus on those. Skin conditions obviously can occur at any age, right from a neonate and a baby all the way into your elderly years. They tend to be more frequent in men and in the elderly. It is estimated that more than 70% of affected people do not consult a physician. Not good. So be sure before you have your skin condition examined, preferably by a dermatologist or a physician that knows their stuff, and make sure you know what you're dealing with, because believe it or not, just by going to Google and searching images and whatever is not a good way to diagnose a skin condition. You really do need to get it properly looked at, maybe a biopsy, whatever the case, just ensure it's nothing ominous or dangerous. And you should always have your skin checked as often as possible, by your partner. Look in the mirror, get mirrors and look around to areas of the body that you can't get to. You get your cat or dog, train them up, make sure they can. No, I'm just kidding. But just make sure you check your skin, because oftentimes if you have like a skin cancer or melanoma that's super dangerous, if it's caught early, it can be dealt with super effectively. So before you use any therapy, including photobiomodulation, go see your doc, make sure you know what it is that you're dealing with, and then you can go from there. Let's talk about probably the most common skin condition, and that's dermatitis. So it causes swelling and irritation of the skin, has many causes and forms, but typically is itchy, dry skin and a rash of some degree, different sizes and shapes. There may be some blistering. Certain types of eczema or dermatitis have blistering, may ooze or crust or flake. The most common ones are atopic dermatitis, contact dermatitis, and seborrheic dermatitis. Atopic dermatitis is commonly referred to as eczema. So that's the one that is predominant. It's not contagious, unfortunately, but it obviously can be a very uncomfortable skin condition, especially when it becomes quite itchy. And when you start to scratch these things, you can get secondary infections, bleeding and all sorts of stuff. So it's important to try and keep it in control. So as mentioned earlier, eczema or atopic dermatitis, that's the most common form. There's lots of factors involved. They're still trying to figure out exactly, but it's not one thing. There's genetic factors, environmental factors. Those are the ones that are known to probably be the main pathogenesis of eczema. Most commonly seen in children, but obviously adults as well. And people with eczema tend to have dry, itchy skin that is prone to infection. The condition is oftentimes referred to as itch that rashes, because dry, itchy skin leads to a rash due to scratching or rubbing of the skin. So the lifetime prevalence of eczema is anywhere from 15 to 30% in children and 2 to 10% in adults. So it's super common. About 60% of cases will develop the disease within the first year of life. So for babies, the chance that they'll continue on and as they grow older, if they have it earlier on. The prevalence seems to be more common in rural areas than urban ones. Not really sure why that is. I couldn't find that out. They probably don't know why. Here's a little fun fact. Eczema is part of a triad known as the atopic march. This relates to the association between patients and atopic dermatitis, asthma, and allergic rhinitis. So about 50% of patients with severe eczema will also develop asthma, and 75% will also develop allergic rhinitis. So this triad that seems to be most common in these particular subset of patients or people with eczema. Okay, that was a repeat slide. There's a genetic component to eczema, which is why I should go over these before I broadcast. There's a genetic component to eczema in which dysfunction causes a leaky skin barrier, allowing water loss and decreased protection from harmful substances. So people with eczema also have reduced numbers of what's referred to as beta defensins in the skin. Beta defensins are host defense peptides, and they're vital for fighting off certain bacteria, viruses, and fungi. So again, if you have any questions, just type in your questions in the Q&A box, and I will definitely get to those at the end of the webinar. It's easier for me to get through the webinar, and now I can address your questions. So a decrease in these specific peptides leads to increased colonization and infection. So you tend to see more Staph aureus on the skin and other types of infection. And this may be part of the reason why you start to see different skin eruptions as well. The main management and treatment protocols for eczema usually is hydration, topical anti-inflammatory medications for flare-ups, but the priority is focusing on daily skin moisturizing regime with a good fragrance-free ointment with limited preservatives. So these are the ones that tend to be more expensive or prescription without any of the perfumes and stuff that are in there that actually may be more of an irritant. So there's other types of eczema as well. So there's contact dermatitis. So I'm going to refer to it as dermatitis, although it's almost synonymous. This occurs when skin comes in contact with an allergen or irritant. There's allergic contact dermatitis. It develops when the immune system reacts to a specific allergen, like latex. You may have a latex allergy, put on a latex glove, and next thing you know, you got something like this, which is this type of contact dermatitis. Then there's irritant contact dermatitis. This is usually when you're using certain substances. It could be detergents or solvents or cleaning products and have a reaction to that. And it will cause a similar looking kind of contact rash. Then you have a fairly common type of dermatitis or eczema. It's called nummular. Nummular is Latin for coin-like. You can see here they're sort of circular pattern and red on the outside. They may be kind of weepy patches. They tend to be very itchy and very persistent. So they'll go away and come back and can occur in different areas of the body, especially the arms, legs, torsos. And oftentimes the triggering is dry skin. So you see a lot more in wintertime. Stress or environmental factors. So part of treatment is to, reduce some of these external factors that you can, including things like stress or environmental factors. Then there's seborrheic dermatitis. This is usually around the scalp, face, or other areas where there's a high density of oil glands. So even in the axilla or the armpit region, it causes redness and scaling and sort of dandruff-like flakes. In infants, you see it initially, and it's oftentimes called cradle cap. Then there's dyshydrotic eczema. You can see here, it's very unique. There's these little vesicles. So there's small itchy blisters, basically. And typically these are on the hands and the feet, and they may be accompanied by redness and flaking. They are very itchy, and the cause of these are unknown, but again, may be related to stress, allergies, or exposure to some kind of irritant. And there's stasis dermatitis. You tend to see these more in the outerly and oftentimes in the lower legs, and it's associated with poor circulation in the veins. So usually you see it along with varicose veins or venous insufficiency. And again, you can see in the picture here, it's quite red and very itchy and swelling. Again, a lot more common in the outerly, and when they start to scratch with thin skin, it can create infections and ulcers and get really nasty. So it's really important that these types of conditions are managed so the patient has a better quality of life. When I say patient, I mean I'm sort of talking to you guys like you're clinicians, and some of you are. But just so you have an idea that when you're treating yourself, I guess you're your own patient. So it's all kind of relative. Now psoriasis, I can talk a little bit about that. It's a chronic proliferative and inflammatory condition, and it's characterized, I'm sure you're aware, by erythematous plaques. Can't say that word today. Covered with silvery scales, particularly over extensor surfaces. So when I talk about extensor surfaces, like that's the back or behind the elbow, and whereas the flexors are the front where you flex, right? So you usually see it on the back of the elbows. That's a common area, or the hamstring area, lumbosacral region. It can even affect joints. So there's something called psoriatic arthritis, and even the eyes as well. There's a form called that, ophthalmic psoriasis. There is no cure. It tends to come and go or wane with flare-ups. And of course, having psoriasis, especially if it's severe, it can really affect one's quality of life, and it can even lead to depression and other mental health issues. So it's really important to try and see what you can do to keep that under control and to improve your quality of life. There are several subtypes of psoriasis. I'm not going to really get into the details, but the plaque type is the most common, and again presents typically in the trunk, extremities, and the scalp. Prevalence is anywhere from 0.2% to up to almost 5% of the general population. It's pretty common. The exact cause is not really known, but it's probably autoimmune. It's probably triggered by a specific type of white blood cell called T lymphocytes. There tends to be a genetic predisposition as well. And certain drugs are known to worsen psoriasis, including steroids, beta blockers, chloroquine, and even NSAIDs. So one needs to look at the meds that you're taking, as that might be worsening your condition. In general, sun and summer is better, less flare-ups, whereas winter is aggravating it. Other aggravating for triggering factors include infections, psychological stress, alcohol, smoking, obesity, hypocalcemia, and there's other triggering factors as well. So if you look at psoriasis, you can see here this sort of white scales or plaquing. I mentioned that in the United States, they say the prevalence is about 2%, but it does vary. And it's considered to be a dysregulation in the keratinocyte turnover, which causes the formation of these thick plaques. So remember, the keratinocytes produce keratin, and it's how these cells are layered. When you have gaps or weakness in these cells, then you start to get overproduction, and you get this type of condition. Where you compare that to eczema or dermatitis, you can see it's a little bit different. You typically know plaquing, more redness, oftentimes vascular formation. So definitely they look different, and these conditions sometimes can mimic or look like other things, so just make sure you get a proper diagnosis. Usually, psoriasis is treated in multiple different ways, from topical therapies like corticosteroids, retinoids. Usually, those are mild to moderate cases. They also use different moisturizers or creams to improve the barrier function of the skin and improve the hydration of the stratum corneum. Now, if patients aren't responding to these types of treatments, then you start to use more powerful medications like methotrexate. Sometimes they use phototherapy. It's a little bit different type of phototherapy, and it's one I haven't really talked about before because it's not photobiomodulation, but it can be extremely beneficial in some skin conditions. It's called narrow UVB band light therapy, or NB-UVB. Usually that's the bandwidth that's used, and it's anywhere in the low 300 nanometers. You can actually buy this equipment Usually you need a prescription to purchase it, and there's these fluorescent bulbs that you expose your skin to. I would say that if you have pretty severe psoriasis, that this is worth a try as well. The downside to this is that overexposure to UV is not good. So the dosaging has to be really monitored carefully, and you have to be careful with it. So there's a potential bit more of a risk for this type of therapy, although it is shown to be very effective as well. So working with a physician that knows what they're doing and understand the dosage, then this might be a really good option. There's a company out of Barrie, Ontario, Canada. I'm trying to remember its name now. I think it's called Solar Tech or something like that, or Solarc Tech, Solrctec, something like that. They manufacture these devices. I know the owner, or I did know the owner. They're a really good company. So if you're interested in it, you definitely would seek that out as well. Then there's other certain types of biological drugs. These are manufactured proteins, and they kind of block the autoimmune response. Now, of course, there's potential side effects as well. Maybe you've seen ads on TV for some of these biological drugs for treating psoriasis. Last condition I can talk about is rosacea. This is a chronic inflammatory disease. Usually see in the face. There's flushing, erythema, sort of little papules or pustules on the nose, chin, cheeks, and forehead. Exact cause, again, isn't really well understood, but there's a probably combination of genetics and immune issues going on. Sometimes there's microorganisms that may be triggering it, environmental factors or neurovascular dysregulation that has to do with the nerve supplying the blood supply. So also there's a known effect of ultraviolet exposure, which may be a trigger as well. So these people with rosacea tend to be sensitive to light, so they need to make sure that they're not out in sunlight too much. Dilation of lymphatic and blood vessels with exposure to extreme temperatures, certain spices, and even alcohol has been observed with people that have this condition. It's estimated here that up to 5% of the population may have this condition. It tends to affect more as we get older into 30 and 50-year age bracket, females more than males. And it's more commonly diagnosed in people with fair skin and up to 10% in Caucasians or white people. Yeah, I don't like using that terminology. It's, there's just different different grades of skin that have different levels of melanin. So people that have very limited melanin, then those are the folks that tend to be more affected. Neurovascular dysregulation, activation of immune system, and infestation with these weird little mites, which are common. Like they're in the skin, but they tend to be more predominant in people with rosacea. There's different subtypes of rosacea as well. You can see here there's vascular, inflammatory, pharyngitis, and ocular, and they have sort of different characteristics as well. So it's important that you get this diagnosed and know what you're treating with as well. Treatment is really part of the treatment is using pH balanced skin cleansers. And these are usually prescription, and there's other types of therapies aimed specifically at reducing inflammation. They may be topicals or systemic drugs. Okay, wow, this that went longer than I thought, which is why I didn't do the 3,000 skin conditions. So why would you use light therapy? Well, I mentioned phototherapy, that's the UV, but photobiomodulation uses red and near infrared. And specifically, we know that it's very helpful for reducing inflammation. And now I won't go into this specific pathway, but photobiomodulation is known to increase macrophages, decrease neutrophils, which help the sort of cycle of inflammation and chronic inflammation. Can also reduce oxidative stress inside cells that are have inflammation with these skin conditions. So it allows these cells to recover and repair much more so than they normally would. So there's an increase in anti-inflammatory cytokines, a decrease in pro-inflammatory cytokines. These are just chemicals released by cells, by white blood cells typically, that help control and modulate inflammation. So when you have excessive pro-inflammatory mediators, then you have more inflammation, and the exact opposite if they go down. And then there's anti-inflammatory mediators. Similarly, if they go up, you have less inflammation. If they go down, you have more inflammation. So photobomb modulation seems to modulate. It's called the immunomodulation. And that's one of the main reasons why it's going to be helpful in these types of skin conditions. Another fact is that photobomb modulation can decrease prostaglandin levels. These prostaglandins cause pain. So some of these conditions, you know, the itchiness and kind of even painful sensations can be reduced with photobomb modulation. The benefit of using red and near infrared is that they can really soak well into the epidermis, dermis, and into the subcutaneous region. Infrared will go a little bit even deeper, but using the two combined ensure that you get to all the different levels of the skin. So remember, there's 4 treatment levels for your device. You can see here, you know, on the far right. And these treatment levels basically vary in specific light parameters, including the pulse rate, and that is a cycles per second, or it's called hertz, and the duty cycle, which is a percent the light is on while it's flashing. And essentially that's the dosaging. And so as you increase the levels, you tend to get more pulsing and more duty cycle. So you can think of it as intensity levels. So what I'm going to suggest is that we're going to use different protocols that may seem kind of weird, like why are you using the elbow or the hand or the neck? And what I've done was I looked at the specific parameters for different protocols built into your machine that are very similar to the protocols that we have used historically to treat these conditions in the sort of professional software. And I'm going to make those recommendations, okay? So for any dermatitis, okay, any eczema, what we're going to ask you to do is start using level 1 of the neck protocol. Now, treating any skin condition takes some time, right? So don't just start changing things willy-nilly after one session. You need to give it some time. And that might be 2 or 3 weeks before you decide to make any changes if it's not improving or was improving and no longer improving. In general, you're going to treat about 4 to 6 times a week. And really until you really get significant improvement going on, that you'll use this neck protocol. Then if the progression isn't improving anymore, or it's not improving, then you can progress to the face protocol, but level 3. So you're going to start off with the neck protocol level 1, and then move to the face protocol level 3. And similarly, do that for several weeks. And if you're not getting improvement, then finally go to the last recommended protocol, which would be going back to the neck, but level 4. Okay, so level 1 neck, then face protocol level 3, and then back to the neck at level 4. And again, this just has to do with the specifics of the duty cycle and the pulse rate that we found effective in our professional grade equipment. For psoriasis, it's a little bit different. So initially, what I'm going to ask you to do is we're going to start treatment with the elbow protocol level 1. You're going to treat 4 to 6 times a week for several weeks until the lesion again is resolved or no longer improving. Then you're going to use face protocol level 3. Right? And then eventually, if you need to, you can progress to the third one, which I'm going to recommend level 4 of the hand protocol. Okay, so for psoriasis, similarly, 4 to 6 times a week. So not every day, but most days of the week. And you're going to start with the elbow protocol level 1, then progress to the face protocol level 3, and then finally the hand protocol level 4. For rosacea, this is a little bit trickier because I want you to treat longer for rosacea, roughly 10 minutes of red. So it seems a little complicated. It's not, but but I'll walk you through it. You're going to start with the neck protocol, level 1, but I want you to use 10 minutes of red. So the way to do that is turn it on and start using level 1 red, and that's only about 6 minutes. Then turn it off, reset, and start again with the neck protocol level 1 for another 4 minutes. Just look at the timer. So then you've done about 10 minutes of red light. At that 4-minute point, then you're going to switch to the hand protocol, but this is for the infrared. Okay, so for that, when you choose the hand protocol, and again, this is level 1, you have to turn it on, let the red light go all the way through. So you're not treating right now, you just set it aside. And then after that's finished, you go to the infrared, which is about 8 minutes of infrared. Okay, so you have to first let the red light run, that's about 5 minutes, I think. And then when it switches over, then you put it on the rosacea. I didn't mention it here or write it down, but you should use the glasses or goggles over your eyes because it is bright and you don't want it to irritate your eyes. It's not going to like harm your eyes, but I don't know why I said that twice, but it could irritate your eyes. So I will suggest that you wear protective goggles. So again, you're going to treat about 4 to 6 times a week for several weeks. Again, if you're seeing improvement, if you're seeing improvement, then just continue. If you're not seeing improvement, then you're going to progress using the neck protocol level 3. So again, you're going to use 6 minutes of red, reset it. So neck protocol level 3, 6 minutes of red, reset, 4 minutes of red. That's 10 minutes of red. Okay, allow the red to finish, and then just continue on with that same neck protocol infrared for 8 minutes. Okay, so it's to recap. Okay, neck protocol level 3, right? 10 minutes of red. So 6 minutes of red, turn it off, reset it, another 4 minutes of red, then let the red finish. That's another couple minutes, then use the 8 minutes of infrared. So that's 10 minutes of red, 8 minutes of near infrared. Then the very last recommended sort of stage I'm going to recommend, if those ones aren't working after several weeks or a month or two, can progress to the hand protocol. So red light, 5 minutes, turn it off, reset it, another 5 minutes, that's 10 minutes of red, and then let it continue on infrared for 8 minutes. Okay, so I hopefully that's kind of clear how you might use that. And again, these are based on the protocols that we found to be effective for these conditions in our professional equipment. Finally, some tips that I'm going to recommend is always consult, I've mentioned that earlier, with a physician for an accurate dose diagnosis. You can talk to the physician about using photobiomodulation. They may not be aware of it, but they may be. Just ensure that it's safe to do so, maybe also consult with if you're taking any medications or whatever, just consult with a pharmacist as well. Ensure that when you're treating your skin, it's clear of any lotions, creams, or medicated ointments. Clean the treatment light pad before and after each treatment. You can use a low-grade, I think it's like 40% alcohol wipe or antiseptic wipe, preferably, spelled that wrong, medical grade, or mild soap and water is also good. To monitor how things are progressing, I prefer that you take pictures and you can do that, the day after each treatment and kind of monitor that and see how you're progressing as well, because sometimes you forget what it looked like. Should your condition worsen, you're having any reaction or whatever is going on, if things just look worse, then obviously stop treatment and see your physician and see what's going on there. It just may be a matter of the condition worsening on its own. Our understanding of photobiomodulation, that there are no known side effects. That is, it's not going to make a condition worse based on this physiological mechanisms of action. If you want more information about these devices or research, we have 2 websites. Bioflexwave.com is for these devices, consumer devices, and we also talk a little bit more in depth about photobiomodulation and professional equipment on bioflexlaser.com as well, so you can visit those sites. And if you have any questions or follow-up questions you want to ask me, David at bioflexlaser.com. There are a few questions. So let me get to those. As personal devices programs are for muscle groups, will you let us know what settings to target specific body areas and conditions? I just did that, so I believe I answered that question. Is eczema considered an autoimmune condition? I think I covered that as well. Does laser work on keratosis pilaris? If so, which settings would you use? I am not sure about that condition. If you'd like to email me and let me see if I can do a little research and see if I can make a recommendation for you. And that is someone by the initials V as in Victor and C as in Charlie. In psoriasis, why start elbow if the patch is on the scalp and fingernails only? Oh, okay. So I said elbow protocol, and you're not starting at the elbow. I'm saying use the elbow protocol or the hand protocol or the neck protocol or any of the protocols I said over the affected area. So I maybe I didn't make that clear, but you're going to choose that protocol, but then treat over that specific area where the lesion is. Uh, Good question here about skin age-related blemishes. Yeah, so it may be helpful for that. And I didn't get into that because that's more of a cosmetic thing, Andrea. Shoot me an email, and I can maybe make some recommendations on that, depending on what type of equipment that you're using and so forth. Is this psoriasis treatment protocol your most recent findings? We spoke about 2 months ago when we were using hand beginning level 1, now in level 2. Should we switch entirely and go back to this protocol? Thanks. So what I did, Gary, is that I think if you're finding, here's the thing with psoriasis, that if you're finding the protocol that you're using right now, Gary, effective, then you can continue with that. I tried to tweak it a little bit, just delving into a little bit more of the research and some of our background information and some of our sort of latest case studies. So if you're finding what you were doing, my recommendations earlier, then continue. If not, you can sort of use these newer recommendations as you see fit. I have the therapist system. How would I adjust the treatments? I also have the wave panel. Okay, for the therapist system, we actually have protocols that you can, specific protocols that you can actually put into your system, Lorette. So Lorette, just give me shoot me an email, and then I can actually share those protocols if you don't have them already. And the wave panel, I don't really recommend. I mean, if that's all you have is an LED panel, it will be helpful. But my preference is to have a device that touches the skin to get the specific dosaging into the tissue, into the skin that has these problems. So the panel isn't the best approach, although if you don't have anything else, it would still be helpful. All right. I think that's it. Although I do have some questions under the chat forum. When treating scalp eczema for someone with very thick hair, should I press on the device the whole time? That's a good question. So what I'd suggest there is that you gently move the device back and forth to displace the hair follicles so that the scalp is closer to the skin. And my preference would be to hold it in place to allow that light to make better contact with the skin. Thanks everyone for attending today's webinar, and I look forward to the next one, which I will put up very shortly. Take care now.